A very good evening to one and all. Welcome to the second edition of the webinar on recent advances. And for the second edition, we have a very eminent speaker, Dr. Ravi Gupta, with two eminent chairpersons, Dr. Raman and Dr. Janvi. I welcome our IPS Vice President, Dr. Vinay Kumar, and this webinar is conducted by the Publication Committee of Indian Psychiatry Society. Indian Psychiatry Society Publication Committee is planning to come up with a book on recent advances. And this is one area which is probably not very well defined, a very fluid, dynamic area. And PG students especially find it very difficult to read recent advances from a particular place or a particular book. So we thought there should be some book or reading material for postgraduates, MD, DPM, as well as the DND students to go through recent advances paper. So in connection with that, we had the first webinar on 28th of October. We had Dr. Adarsh Tripathi giving introduction to recent advances. And today we have Dr. Ravi Gupta, who will be speaking on sub-specialities in psychiatry and recent advances related to the field. We have two eminent chairpersons, Dr. Janvi Khedare, who is additional professor at TN Medical College and Nair Hospital, Mumbai. Welcome to you, madam. It's a pleasure to have you here.
Thank you for having me here.
The second chairperson is Dr. Raman, who is also having a PDF for postgraduate fellowship in child and adolescent psychiatry from CMC Vellore. He is professor of psychiatry at Savita Medical College and Hospital, Chennai. He had received the Young Psychiatrist Travel Fellowship in 2009, the Nilofer Award in 2011, and the Must Enrich Grant Award for Indian Teachers of Psychiatry in 2020. He has more than 25 publications in index journals, and his areas of interest are school mental health and postgraduate training. Welcome to you, Dr. Raman.
Thank you, Dr. Anil.
Yeah, I welcome my fellow colleagues in the publication committee who are present here, and I request Dr. Vinay Kumar, our IPS Vice President, to say a few introductory remarks before the topic opens. Over to you, Dr. Vinay, sir.
I think he has gone offline.
Okay.
Here he is. Here he is.
He is there. Dr. Vinay Kumar, we are waiting to hear you.
Am I audible?
Yes.
Hello.
Yes, sir.
You see, I am traveling and internet connection is coming and going. So, am I audible?
No, we can't hear you.
The audio is not clear, sir.
No, it is not.
Traveling is big issue. I'm not able to manage. I think signal is very poor. So kindly continue with the program. Today you have very good speaker. I think Ravi Gupta is one of the best teachers of country, and I'm sure he will explain all the sub-specialities and all. I think I am not audible. Signal again.
No, you are audible, sir. We are able to hear you. Thank you. Yes.
Kindly. Okay. Okay. So kindly one of the best teachers, and we have many very good presentations by him on different things in sleep medicine, especially on melatonin and other sleep medicine. I just our all to YouTube sites to listen do justice, and he will cover all important times of need.
Thank you, sir. Thank you, sir. Some connectivity issue, but I thank you for sparing your time in between your travel. I hand over the proceedings to our chairpersons, Dr. Janvi and Dr. Raman, and to introduce the topic and introduce the speaker, and then we move on to hear the much awaited topic from Dr. Ravi Gupta. Over to Dr. Janvi.
It gives me great pleasure to introduce today's renowned speaker, Dr. Ravi Gupta. He has given a very short introduction of himself. I think Dr. Vinay Kumar did more justice to his introduction than he himself did it. He is a professor of psychiatry in AIIMS Rishikesh. I'm sure it's getting colder and colder in Rishikesh, and the weather must be really pleasant. I think he's the right person to speak about subspecialties in psychiatry. He is working in one of the, let's say, subspecialties. If you consider sleep medicine as a subspecialty, then yes, he is working in one of the areas, and I'm sure he'll throw light on various aspects that we all think about and work in depth, and giving rise to many more subspecialties than what we have been discussing till now, probably. And that is why it is a very apt topic for a national webinar on recent advances in psychiatry. He told us to introduce him in only one sentence, and that just shows how humble he is and a very keen academician. Over to you, Dr. Ravi Gupta. But before that, I think Dr. Raman would like to introduce a little bit about the topic. Over to you, Dr. Raman.
At the outset, I would like to thank the publication committee of IPS for inviting me to be one of the chairperson with eminent co-chairperson, as well as one of the very good speaker. And it's my pleasure, Dr. Anil. And the topic for today is recent advances in subspecialty. So basically, we know that like specialization or subspecialization, are we looking at narrowing down from the broad specialty, or are we looking at expansion of the field of psychiatry? So I think Dr. Ravi Gupta would be able to throw light on the various subspecialties, which I think most of the postgraduates would be aware of, the commonly existing subspecialties like child psychiatry, addiction, geriatric. But there are a lot more added to the pipeline. Like I'm sure like there are recent advances in interventional psychiatry, like neuromodulation is being talked about as part of the interventional psychiatry as subspecialty. And psychotherapy in Western countries has become one of the subspecialty. And even under child psychiatry, they have just broadened down into further subspecialties. So I think we have a lot more to actually hear from Dr. Ravi Gupta, sir. And the challenges are also very important, because in terms of training, creating a blueprint for the training of the and manpower. So over to Dr. Ravi Gupta, sir, on the topic.
Thank you, ma'am, for the kind words, and also Dr. Raman for your kind words. And I'm really thankful to the IPS Publication Committee for giving me this opportunity. So today's topic as given to me is the recent advances in subspecialties in psychiatry. So this is my disclosure. I am working on the advisory board for the Blackbird Technologies India Private Limited and ISA India Pharmaceutical Limited, and I am getting royalty from the Elsevier, Apple Academic Press, and Springer Nature. But none of these my financial disclosures would affect my today's presentation. So today we'll talk about how, because this webinar is primarily aimed towards the postgraduates. So we talk about the need for updating yourself. Why do you need the recent advances? What are the obstacles? What are the opportunities and how to move forward? Then, as already discussed by Dr. Raman, there are a number of subspecialties in psychiatry. For example, we have the DM in the addiction psychiatry, we have the DM in the geriatric psychiatry, we have DM in the child and adolescent psychiatry in our own country. And there are a number of other subspecialties like interventional psychiatry, perinatal psychiatry. They are also emerging, and the consultation liaison psychiatry. But say to include all the recent advances in all the different branches of the psychiatry, it's difficult. So I chose to limit myself to the recent advances in the sleep medicine. So we will discuss what has happened in the sleep medicine in past 4 or 5 years, and then I'll summarize my presentation. So first, when we talk about the recent advances, so why do we need ourselves updating? So first of all, say when most of the postgraduates, they are appearing in the examination, then they have a dedicated paper, which is usually the paper 4, which is aimed as assessment of the knowledge towards the recent advances. Similarly, many of us who are beyond post-graduation, maybe doing our super specialization or say practicing or maybe working in the teaching institutions. So at times we think of conducting some kind of research, and we cannot conduct any research unless we are updating. And lastly, most importantly, because we are the doctors, the medical doctors, so for us, the most important thing which gives us satisfaction is the patient care. And the patient care also require the update, the regular update regarding the recent advances, so that we can provide the best available therapy to the patients. So when we talk about the examination, so most of in the MD exam, usually it is the paper 4, which is dedicated for the assessment of the recent advances. Now we have 2 different kind of examinations. One are the subjective examinations where you have to write in detail. And secondly, say some of the institutions, for example, AIMS Rishikesh so far is going with the examination in the MCQ-like pattern. So, say having these kind of examination, you have to be updated. So there are, when we talk about the updating ourselves in different recent advances, then we need to first understand the different concepts in the recent advances. So for that, we can take the help of the books and we can review the important papers which are published in the journals. Mainly the meta-analysis, systematic reviews, narrative reviews, scoping reviews. There are so many different kind of reviews which are available here. And similarly, we have something known as network meta-analysis. Then we have guidelines. Then we have consensus papers. So you can go through all these papers. If there is a single paper, you can go through that paper, or you can, if there are multiple papers available, so to update yourself, you can compare what has been mentioned in different papers. And usually when we talk about the recent advances for the post-graduation, so we want the post-graduation to know what the advancement has occurred during the tenure in the post-graduation. Then they must also know some important historical papers which are important for the psychiatry as a specialty as well as the subspecialties. For example, STAR-D trial. For example, we talk about the RDoC criteria, or then we have certain landmark studies. For example, the PGI conducted the IPS study, IPSS study. So these are our important studies, and which we think that a postgraduate must know. Coming to the research, most of the postgraduates, they have to write a thesis. So during the review of literature, they have to, the major aim is that they should understand the methodology and they should able to understand how to review the literature, how to make a conclusion out of the different original articles. Then many of us who are practicing, who have completed our residency and now in the different levels of our career. So at times we plan the research project. So when you are planning a research project, definitely you want a research question, and research questions can emerge from various settings. For example, when you are seeing a number of patients, then the particular observation in the patient can give you a research question. But ultimately, when you are observing something, then ultimately you have to go back to the literature and you have to find out what is already known in that area and what is not known. So again, when you are planning the research, at that time, the recent advances are important. Then when you are doing the project, at times you want to assess the midway so that you can tweak in your methodology. Similarly, when you are writing your report, then you have to compare, in the report, you have to compare your data with the previous publications. So at that time, you need the updating when you are sending a paper for the publication. And importantly, when you are planning a follow-up project from the previous project, then again, you need some update, because in any project that you do, that always leaves some questions unanswered. And then you have to look at the literature which is available towards those questions, and then you have to find out what is to be done and how it is to be planned. And lastly, as medical doctors, we have already talked about that we have two major responsibilities. First, we have to diagnose the patient accurately and precisely, so that we can give him the best available treatment. And we need to update when we are doing the patient care for our own satisfaction, because I think as a clinician, that satisfies us most is a smiling patient or the smiling relative when they come up in the follow-up visit. Of course, as a medical doctor, it is our duty to provide the best possible care. And lastly, in the past few years, the medical legal cases against the doctors because of the negligence, whether it is at times maybe because of the ignorance or because of any other reason. So they also occur. And if you are updated, then you can avoid many of these medical legal issues. So let's look at what are the opportunities which are available for updating ourselves. So first of all, postgraduates, they usually work together, and they are they are staying together in the hostel. So postgraduates, I would urge the postgraduates to discuss whatever patients they are saying, whatever they are reading, because more you discuss and more you become wiser. What are the areas that you don't know, or what are the areas that the literature does not give an answer to, and what do you need to read further. Similarly, when you are talking to your colleagues in the other specialties, then they give you a different perspective regarding a same illness, or maybe in any condition which is comorbid with other psychiatric disorders, and that actually helps you in the proper diagnosis as well as the management of the patient. Similarly, I would urge you to, as far as possible, please interact with your seniors, with your teachers, with your mentors, because they have crossed a particular level of understanding the subject, and they can definitely guide you. They can give you insights about the nuance regarding the nuances and the finesse of the subject and a particular topic. And many of your teachers are working in the subspecialties. So whenever you are having a case regarding any of the subspecialties, please go and discuss with your teachers, because they will be able to provide you altogether different kind of viewpoint for looking at your own case, and that can help you in managing that case and also give you some clue to what to read. Then when you are seeing the patient, most of you must be having the smartphone now, so you can use your mobile, you can use the Google or UpToDate, or an Elsevier product like IPOC is available, or maybe Medscape. Then you can go to the PubMed. So there are a number of different sites which provide you the latest available medical evidences, and you can go to that and you can read about that particular topic at the bedside. Then number of podcasts, webinars, and as we are doing today, and the CMEs are also available. Many of the CMEs are in the physical mode, and many of them are say occurring in the online mode. So you should attend as much CMEs as possible and the webinars, because that help you to update your knowledge. But what are the obstacles? Of course, when there are opportunities, then there are some obstacles to the updation of the knowledge as well. So first, being a medical teacher myself, I would say raise finger towards myself. So when I talk about the qualities of the teachers, some of the teachers, they would like to be updated, and they are updated in the diverse areas of the topic. Some of the teachers like me, we are working in a particular area. So of course, because any of the area, if you pick, and this is actually an era of information overload, so you have so many articles to read that one cannot remain updated in all the areas. So, but many of us say, I mean, I'm not sure whether I should say it or not, but yes, many of the teachers are not updated. Many of us are not open to the newer understanding towards the subject, or the newer concepts or newer understandings or newer viewpoints which are put forward by the residents and the other colleagues. But those who are open, definitely they are able to energize the environment, and they always come up with the new questions to work on for themselves as well as for their departments and colleagues. Most of the teachers, I would say that we are supporting to the academic endeavors of the postgraduates, but some maybe you can count such teachers on the fingers, but they may not be supporting because of various reasons, and that lack of support is not an kind of omnipresent thing. They can be busy somewhere because of certain other issues that they are going through, so they are not able to show the support to the postgraduates, and at that time the postgraduates feel that say they are not able to upgrade their knowledge. But yes, I can say this, that most of the people who are working in the academic institutions and who are having the direct interactions with the postgraduates, and the very good thing that I have seen these days, that most of the people who are working even in the private sector, they also are delivering lectures, and they are also organizing the webinars, and they remain updated. So that is something which is a very welcome change. So I think there are lots of opportunities when we talk about the updation. So when I raise the finger towards myself and my colleagues, then of course I have a right to raise the fingers towards the students as well. So we get a different kind of students. Some of the students, they are actually interested in the topic, in the subject. So they like to remain, they have a very keen observation. They like to remain updated. Many of them, and I would say most of the students, they are motivated to be updated. Most of the students, they are persistent, and they actually look towards a particular topic or the question which has been given to them till the time they find the answer. Most of the students, they are open, and they actually try to understand the viewpoint of the teacher, and also whenever they have their own viewpoint, so they try to compare the two, and they try to reach to a particular conclusion by discussion with the teacher. And the different students, they have different levels of elementary knowledge, which what I call as foundation. So some students, what I have seen, that they have a very tunnel vision, and they do not want to look beyond what the quote unquote psychiatric disorders, what have been described in the DSM-5 and ICD-10. But friends, please remember that when a person is coming to you, a person is not coming to you because he's suffering from a particular disorder. he may at times be suffering from other medical disorders which might be say having a similar presentation to the psychiatric disorders, or they may be having a comorbid disorder. So please try to improve your foundation regarding the medicine and the elementary neurology at least, because unless you have a good knowledge regarding the medicine and the neurology, you cannot become a specialist in psychiatry. So these are the different qualities of the students, and they vary on these qualities to different scales. But yes, what I can say that I have worked in a private medical colleges. I have worked now I'm working in a government institution. So I have seen that most of the students, they possess these qualities and they actually are motivated to learn. Then another obstacle to our updation is the resources. Some of the institutes, they are having very good libraries. So we have ample number of books, ample number of journals regarding the general psychiatry or the subspecialties of psychiatry. But in some institutions, some places, they are not available. So this availability of resources also can influence the way you remain updated and your ability to remain updated, even when you are, say, motivated to keep yourself updated. And I think that is something which we can work on as the teachers, and maybe there are certain number of open access journals which are now available, so you can read those to keep yourself updated. Now, talking about the need for the updating, and we have talked about the opportunities and the requirement and the need and what are the obstacles. Now we move forward, and what should we do? So friends, please remember, this is an era of evidence-based medicine. And the evidence-based medicine is defined as a conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patient. And what does it mean? That you are integrating the individual clinical expertise with the best available external clinical evidence from the systematic research. So I have seen many students who try to say follow the guidelines in letter and spirit, but please friend, please remember that whenever we talk about the guidelines, whenever we talk about any other evidence, meta-analysis, network meta-analysis, please remember that these papers, they include the different sources where a particular type of patients they have been included in these studies. Now, and those patients which have been included in those studies may not be similar to the common patient that you are getting in your own practice. So there comes the role of the individual clinical expertise. So more the number of patients you see, more you see them in depth, more you try to learn about the individual characteristics of different patients and how they are responding or how they are presenting, the better you are able to inculcate the best available evidences into your clinical practice, and you are able to provide the best care to your patients. So when we talk about the evidence-based medicine, the principle is that you must be aware of the best available evidence. The evidences, they have different hierarchy. So you should be guided by the hierarchy of the evidence which are available. And we will discuss about the hierarchy of evidence in the next slide. Then clinical decision should not be based on the evidence alone. You might be getting some evidence that a person must go, say, fMRI in this particular condition. But there may be patients who are not ready for it. There are the places where fMRI is not available. There are patients who are not able to afford the cost. And then you have to look whether the fMRI is going to give you some benefit and what are the risks associated with it. So when you are considering all these aspects and then you are trying to apply what the best available evidence, then this is now what is known as evidence-based medicine. So please, friend, don't try to replicate whatever is written in the guidelines in lateral spirit on your patients, because that may do more harm than helping the patient and yourself. So when we talk about the best available evidences, the best available evidences comes from the systematic reviews as well as the meta-analysis of RCTs. And now we have the network meta-analysis, which is again going for different kind of meta-analysis and the individual studies, and they try to find out the strength of the evidence among the different available therapies or the diagnostic modalities. So please choose the quality of evidence which is higher in this pyramid and which is having the lower risk of bias in this pyramid. So that comes to again the systematic reviews as well as and the meta-analysis and the network meta-analysis. And you can also use the guidelines, because most of the guidelines these days are not based on the consensus alone. Most of the guidelines, they are proposed by different societies using the grade criteria and after a meta-analysis. Now, how to start a search? First, whenever you are seeing a patient, then you should, from that patient, there can emerge a question. So decide what is the question. And 4 major characteristics of a good question is the PICO format. So P stands for population, I for intervention, C for comparison, and O for outcome. So we will see it through an example. Then once you have a question, please search in the major search engines like PubMed, maybe you can go UpToDate, Cochrane, and there are a number of other search engines that you can use. When you find an evidence, look for the authenticity as well as the scientific robustness. Look for the limitations which have been mentioned in the evidence itself, because some evidences may be available, but there may be having certain limitations, and your patient might be falling in that limitation. So these guidelines or the evidences might not be applicable to the patient in hand. And after having all this, please use the information for in your clinical practice as well as research. So let's try to look an example. So you get a 30-year-old male who is complaining of insomnia for past 10 years. He does not have any other comorbidity. He has been on hypnotics and sedating antidepressants and sedating antipsychotics like olanzapine and quetiapine, sometimes alone and sometimes in combination in the optimal doses for the optimal duration. But none of these pharmacotherapies has seemed to work in this patient. And the patient is still complaining of insomnia. The question is now what to do in this case. So what are the possible issues? First is that the diagnosis of insomnia could be incorrect. So there are some disorders which the patient is suffering from and which can mimic actually the insomnia. So we are treating the insomnia rather than treating the disorders which are mimicking insomnia. It is also possible that the person must be having some kind of comorbid medical disorder or comorbid psychiatric disorder, which still is not being addressed to, and that is leading to the partial improvement. Or there is a possibility that the patient is showing the resistance to the treatment. So when you see the treatment resistance, then you should see whatever medications has been given to the patient or has been offered to the patient, do they have a role in treatment of insomnia? And then try to find out what has been already offered to the patient. Do we have anything besides that? So for example, for insomnia, we know that there is something known as cognitive behavior therapy for insomnia. So you may think, yes, I would consider therapy for insomnia in this case, but before you try to go for that therapy, you should try to find out what is the evidence available for the treatment of the insomnia, for the CBTI in the insomnia. What is its efficacy? What are the limitations? And how does it work? So I tried to search the Google Scholar with these questions. So coming to the incorrect diagnosis, so I gave the keywords like disorders, mimics, adults, insomnia. So I received a number of papers. Now, if you go through all these, this doesn't appear to be something important for our question in hand. So all these top 4 papers, they are actually not something which we want to answer to. So, and then we finally find one paper, it says when insomnia is not just insomnia. So probably it is talking about the disorders which are mimicking the insomnia. And when I opened this paper, I found that there are a number of other disorders which are actually, which can mimic insomnia. So this gives me an idea that, look, I have to look for these disorders, or maybe if I'm not well equipped, then I have to take the help of some of my colleague or the senior or the teacher or the mentor. Or if the help is not available, the requisite expertise is not available in my own institution, then probably I need to refer to a specialist. Similarly, when I chose the diagnosis, so I looked for the comorbidities, insomnia, reviews, and in the adults. So again, you can see there are a number of papers which have appeared. So the first paper itself says that the prevalence of chronic insomnia in adults with medical comorbidities. So definitely it is a good paper I should go through, because it will help me to find out the other medical morbidities which can be present and which might be obstructing the adequate treatment to this patient. Then thirdly, coming to whether the patient, why the patient is not improving despite different kinds of hypnotics. So I searched with the keywords hypnotics, adults, insomnia, meta-analysis or guidelines, and I found all these papers. And you can see here the number of papers which are basically the guidelines. This is the meta-analysis which talk about the effectiveness of non-benzodiazepine hypnotics in adults. Then sedative hypnotics, meta-analysis of risks and benefits. So these are the papers which appear, and I can go through these papers, and this can help me to find out, what are the role of the hypnotics, and if they are not indicated, then what should I do next? And lastly, when I talked about the alternative treatment, so I looked for the CBTI, adults, insomnia, meta-analysis guidelines. So I got all these papers, and these papers talk about the efficacy and the guidelines regarding the CBTI in the adult chronic insomnia. So those papers can be downloaded and they can be referred to have a better understanding regarding this case. So with this background, I'll just, because it's basically a webinar which is aimed for the postgraduates, so I'll focus on the recent advances which have occurred in the sleep medicine during past 3 or 4 years. So first of the recent advances that occurred is the guidelines which appeared regarding the use of actigraphy. So these guidelines suggest that when I use the word suggest, though this shows that we don't have a robust data regarding its use. So these are not recommended, but yes, you can use depending upon your clinical judgment. So the available data suggests that actigraphy can be used to assess the various sleep parameters like sleep onset latency, total sleep time, wake after sleep onset, wake after sleep offset in the adults and pediatric patients of the insomnia. They can be used for the assessment of circadian rhythm sleep disorders like delayed sleep-wake phase disorder, shift worker disorder, advanced sleep-wake phase disorder, irregular sleep-wake rhythm disorders in the adult and pediatric patients presenting with the either insomnia or hypersomnia. Then when you are doing a home sleep study, you can use the actigraphy to assess the total sleep time in the patients who are suffering from obstructive sleep apnea. Then you can use the actigraphy to monitor the total sleep time before you commence the multiple sleep latency test in the adult and pediatric patient complaining of hypersomnolence. And many of the patients who are coming with the hypersomnolence, a great chunk of them, they actually suffer from what we call as insufficient sleep syndrome. And in those cases, to assess the total sleep time, actigraphy can be used. But these guidelines suggest that you should not use the actigraphy for the assessment of periodic limb movement disorder in place of leg electromyogram. So this is something which not to be used, because this will not give you the data similar to the leg EMG. Coming to another problem, common problem, the insomnia. So insomnia is common in patients suffering from psychiatric disorder, whether we talk about the anxiety, depression, bipolar, schizophrenia, substance use. But very unfortunately, we do not give a separate diagnosis of the comorbid insomnia, which many of the patients they require, and that is the reason many of our patients they not respond fully to the treatment. So most commonly what we are doing in our own clinic, our own country, because of the limited resources, is the pharmacotherapy. So these are the clinical practice guidelines which appeared in 2017. They were proposed by the American Academy of Sleep Medicine. So they suggest that for the sleep onset insomnia, you can use zaleplon, triazolam, or remeltion, compared to not offering any treatment. For the patients who are complaining of sleep maintenance insomnia, that means the middle insomnia, you can use suvorexant, lemborexant, and doxepin. And the patients who are complaining of both the sleep onset insomnia as well as middle insomnia, you can use the zopiclone, zolpidem, and temazepam in the pharmacological doses. I'm not going into details regarding this because the time is short. But these guidelines suggest that the use of trazodone as a hypnotic, tiagabine as a hypnotic, diphenhydramine or melatonin or tryptophan or valerian as a hypnotic can do more harm than the good. So they should not be used as a hypnotic therapy. Coming to the CBTI, so the guidelines suggest that the multi-component CBTI, which is having the relaxation therapy, which is having the sleep hygiene, which is having sleep restriction therapy, which is having stimulus control therapy, which is having the mindfulness therapy, which is also having the JPMR. So this multi-component CBTI is something which is effective for the treatment of the chronic insomnia, and it is recommended. Brief multi-component CBTI, we have limited data regarding that, so can be used if you are not proficient in the multi-component proper CBTI. The single components of the multi-component CBTI, they may be used in the individual cases, but they are not very effective. But just using the sleep hygiene as a single component for chronic insomnia in adults is not going to benefit the insomnia. So this should not be used. Coming to another common problem, the obstructive sleep apnea. Nearly 50% of the patients who are suffering from mood disorders or schizophrenia or bipolar disorder, they suffer from obstructive sleep apnea. Very unfortunately, we do not pay attention to the comorbid OSA, and we keep on treating the patient with different kind of other agents like modafinil or any other agent for improving the daytime sleepiness and the hypnotics, or we keep on increasing the dose of the sedating antipsychotics or sedating antidepressants for the nighttime difficulties in the sleep when actually the person is suffering from sleep apnea. I'll not go into the details because the time is not permitting me regarding the diagnosis of OSA. But these guidelines, they were proposed regarding the use of the home sleep apnea testing in children aging less than 18 years. So the home sleep apnea testing, which is very common these days, especially by the pulmonary colleagues and the ENT colleagues for the diagnosis of insomnia, obstructive sleep apnea, they are not at all recommended in children because we do not have any data regarding their comparison with the gold standard in lab attended polysomnography. Moreover, home sleep apnea testing lacks the CO2 sensor or capnography, and it does not have the EEG, so we cannot estimate the arousal, the micro arousals. So it is not recommended. Now the children, their body size varies and their cognitive development, even for a given age of children, is different. So whether they will be able to tolerate these many sensors is again not sure. So it differs, and that is the reason home sleep apnea testing is not recommended. And the caregivers who are to apply these different sensors in the home sleep apnea testing, their motivations towards the testing and their patience when the child is say not allowing them to place the sensors can also vary, and that is the reason home sleep apnea testing is not recommended. So whenever you have a child with the suspected obstructive sleep apnea, please refer him for the in-lab attended polysomnography. regarding diagnosis of OSA in adults, please do not use the clinical questionnaires or the algorithms for the diagnosis of OSA in absence of polysomnography or home sleep apnea testing or portable polysomnography. Those patients who are having uncomplicated OSA, complicated OSA means those people who are suffering from OSA along with cardiorespiratory disorders or neuromuscular disorders, who are having the daytime or nighttime hypoventilation, who has suffered stroke, who are having comorbid insomnia or chronic opioid use. In those cases, home sleep apnea testing is not recommended, and these patients have to undergo the in-lab polysomnography for the diagnosis of OSA. But other patients, adult patients who are showing the signs and symptoms of only the OSA, in those cases, you can go for either the in-lab testing or the home sleep apnea testing. Now, whether we should repeat the polysomnography? Yes, when the single home sleep apnea testing is negative or inconclusive or technically inadequate because of the fall of sensors or inadequate data, then you should go for the repeat polysomnography in those cases who are having high clinical suspicion for obstructive sleep apnea. A split night protocol for the in-lab PSG is something which is suggested because we don't have any robust data regarding whether it does work, similar to the 2 nights of the study where first night is given for the diagnosis and second for the titration of PEP. And repeat PSG can be done when the initial PSG is negative and patient is still having the very high clinical suspicion regarding having sleep apnea. Once you have diagnosed the person with the sleep apnea, then you definitely like to offer the therapy. So most common kind of therapy that we can offer to these patients is the PEP therapy. So PEP therapy is recommended in all the patients of the OSA who are having daytime hypersomnolence. The PEP, we have 2 different kinds of PEP. That is, one we do the manual titration in the lab where we try to find out a particular pressure, which is effective for the treatment, or there is something known as automatic PEP, which keeps on increasing or reducing the pressure based upon the respiratory events which are occurring during the night. So they can be given, either of them can be used in the patients without comorbidities. But when the patient is having comorbidities, as we have discussed earlier, the neuromuscular, cardiovascular, cerebrovascular, or other sleep disorders, then they should undergo only and only to the manual titration. All the patients must be educated regarding the regarding the sleep apnea, need for the treatment when you are initiating the therapy. And the patients of the sleep apnea who are having impaired quality of life or who are suffering from hypertension, in those cases, PEP therapy may actually help. So this can be used based on the case-to-case basis and using your clinical judgment. It should be used for the routine treatment. Now, whether you should train the patient regarding the troubleshooting interventions with the PEP therapy at the initiation is again which is suggested. So you can choose. If you have time, then you should do this. If you don't have time, then you don't do it. And if the patient is struggling with these kind of troubleshooting problems, then you should give these kind of interventions, and you can educate the patient regarding it. Whether you should follow up the patient using the telemedicine, yes, you can do it if the telemedicine is available, but it is better to have the PEP clinic in your and see the patient in person along with the PEP device in your practice. Coming to the long-term management, so follow-up study is usually not recommended. Follow-up sleep study is not recommended in the asymptomatic patients with the OSA who are already using the PEP therapy. But the people who are using the non-PEP interventions, for example, mandibular advancement devices, or they have undergone some kind of surgical therapy like the ENT surgery or the soft tissue or the bony surgery like mandibular advancement or maxillary advancement, in those for regular follow-up with the polysomnography is recommended. When the patient is showing some kind of signs or recurrence of symptoms despite the good PEP adherence, then you can again again do a sleep study to find out the possible reasons. If the patient has undergone weight gain or weight loss, which is significant, that means more than 10% of the baseline weight, then you should repeat the polysomnography, because that can actually help you to either increase or reduce the pressure. If the patient has developed, who is already on the PEP therapy, if has developed the sleep-related hypoxemia, as we see in COPD or the asthma, or this hypoventilation as we see in COPD or ILD or the neuromuscular disorders, then you should repeat the polysomnography. Or the patient has developed, or there is a change in the existing cardiovascular disorder like hypertension, CAD, then you should do a repeat polysomnography. Coming to the nightmares. So when the nightmares are associated with the post-traumatic stress disorder, then only the image reversal therapy is indicated. But CBT, CBT, eye or eye movement desensitization can be used if the patient is tolerating. Now, certain antipsychotics, antidepressants, anti-epileptic drugs, prazosin, phenelzine, and clonidine may be used, so they may bring some kind of improvement, but we don't have any robust data regarding the use of these medications when the nightmares they are associated with the PTSD. But when it comes only to the nightmare disorder where we don't have the PTSD and patient is still having the nightmare, then you can use we don't have any robust data regarding which therapy to be used. So it has been suggested that either the CBT, hypnosis, lucid dreaming, or deep muscle relaxation can be used as a therapy, and they can bring some improvement. Prazosin, triazolam, or nitrazepam can be used, which can bring some improvement. But please don't use clonazepam and venlafaxine, because we don't have any scientific evidence so far regarding their efficacy in the treatment of the nightmare disorder. Now, coming to another common problem that we see, that is the central disorders of hypersomnolence. So first we talk about the narcolepsy. So for the treatment of narcolepsy in the adults, the recommended therapies are modafinil, pitolisant, sodium oxybate, and sodium and the armodafinil, methylphenidate, and dextroamphetamine. We have limited evidence regarding that. So they may be used for the treatment, but the upper four are recommended. So we have robust evidence regarding them. Regarding the pediatric, we don't have any robust evidence. So you can use either the modafinil or sodium oxybate, because some of the RCTs, they show that they bring some improvement in the narcolepsy in pediatric patients. Coming to the idiopathic hypersomnia in adults, so only the modafinil is recommended. Clarithromycin, methylphenidate, pitolisant, and sodium oxybate can be used. So in some patients, they may bring some improvement, but not all patients. So, and modafinil is easily available, cheap, and the very safe drug. So that is something which is recommended and can be used. If you have got a patient suffering from clean living syndrome, so we don't have any robust data, because this is a very rare disorder regarding its pharmacotherapy. So we don't have any RCT on it. So what has been suggested from the case reports and case series, that we have decent evidence that lithium might be effective in treatment of clean living syndrome. When we talk about the hypersomnia, which is associated with the other medical conditions, for example, alpha-synucleinopathies, then in the patients with dementia of Lewy body, you can use armodafinil. In the patients suffering from Parkinson's disorder and comorbid hypersomnia, you can use modafinil and sodium oxybate. In the post-head injury hypersomnia, you can use armodafinil or modafinil. Patients who are suffering from myotonic dystrophy, in those and the comorbid hypersomnia, they should first undergo the polysomnography, because many of them might be suffering from sleep apnea, and after that you can use, after the optimal management of sleep apnea, you can use modafinil. In the patients who are suffering from multiple sclerosis or any other space-occupying lesion of the brain, you can use modafinil for the management of hypersomnia. So in summary, what we can say that updating is something which is important not only for your clinical practice but also for the research as well as the best patient care. You have a lot of opportunities where through where you can update yourself. There are number of obstacles, but they are surpassable. And the only thing is you have to identify the correct method to update yourself periodically, and that has to be adopted, and that will definitely help you to remain updated and be a good clinician and good researcher and a good teacher as well. Thank you very much again, the IPS committee, for this opportunity. And if there are any questions, I'll be happy to take them.
Thank you. Thank you, Dr. Ravi Gupta. That was a really comprehensive review of recent advances in sleep disorders. That is one. But I think what you did was how to approach recent advances in any specialty of psychiatry is what you spoke about, and it should serve as a good guidance to the postgraduates. I would say not just postgraduates, to even seniors like us who want to keep our knowledge updated. I think these are the this is the pathway that we can definitely follow. Rather than naming and describing specialties, what you did was gave us a guideline as to how to approach any subspecialty in psychiatry. I think over to Dr. Raman for his comments, and then let us see if there are any questions.
Thank you, Dr. Ravi Gupta. So coincidentally, I would like to share that in the institution where I'm also working, they have started a Center for Sleep Health, which is headed by people from neurosciences and pulmonologist and ENT specialist. So I think we are just looking forward to establishing the sleep medicine. So that is I got a lot of input from your experience as well, sir. So we have few questions. Ma'am, would you like?
Please go ahead.
Okay. So I think some students have asked or dose brand efficacy of S-opiclone, and is this included in is it included in sleep medicine? Please, I didn't get that. So dose brand efficacy of S-opiclone, sir, is what he just wanted to know.
Dose brand efficacy, I'm not really sure.
Yeah, I also did not get the question right. So maybe you can just highlight efficacy of S-opiclone overall in insomnia.
Yes, S-opiclone is a very good medication. Unfortunately, it is not available now in India. It was marketed around 15 years back, but somehow it was discontinued. So it is not available as of now, but you can use in that place, you can use the zolpidem, which is available, and also the zaleplon, which is also available. So unfortunately, S-opiclone is not available as of now in India.
As quetiapine is used up to 200 milligram for sleep, but if we keep increasing the dose, what will be the effect on sleep?
Well, if we talk about, as I already discussed regarding the clinical practice guidelines for the insomnia, use of the sedating antipsychotics, whether we talk about the quetiapine or we talk about olanzapine, is not recommended unless the patient is having comorbid psychosis. Because there actually definitely you would like to choose, because this will help both ways. But in the patients who are suffering from only the chronic insomnia or chronic insomnia with say depression or any other thing, please do not use this medication because it can do more harm than the benefit. So please stick to the classical sedating hypnotics, which includes the benzodiazepines, Z drugs, and now we have the third kind of hypnotics, which are basically the dual orexin receptor antagonists, and the lemborexant is already available in India.
So maximum dose of modafinil in narcolepsy.
Well, the maximum dose is definitely the therapeutic dose. We start with the 50 milligram, and then you can go up to the 200 milligram, but definitely should not go beyond that, because that can lead to the adverse effects. So if at that dosage for the optimal duration, if it is not working, please switch on to the other medication. And when I talk about the efficacy of the modafinil in narcolepsy, it will help only to reduce the sleepiness, but not the other parts of the narcolepsy, especially if it is the cataplexy. So for that, you have to use either the SSRI or the TCA.
Thank you, sir. We know clobazam is least sedating, but can we still use in insomnia?
Yes, of course. I mean, say when we talk about the comparative efficacy of the benzodiazepines, so it's very difficult to ascertain whether there is a comparative scale regarding the sedation in the benzodiazepine. I think that is more of the dose dependent, and also we have some kind of idiosyncratic reaction, because we have seen certain patients who feel very sleepy even on the 0.25 milligram of clonazepam or 1 milligram of diazepam. Then there are patients who are able to tolerate 10 or 20 or even 30 milligram of diazepam, or even the 3 or 4 milligram of clonazepam without any sedation. So I think the dose you need to ascertain using the individual patient and looking at the clinical response. But I don't think clobazam is heavy, not to my knowledge, where I can say that the clobazam is less sedating compared to diazepam or clonazepam.
I think one more question has come, Dr. Raman, in the chat box.
Yeah. Modafinil and sodium oxybate FDA approved for narcoanalysis.
Narcolepsy, I think.
Narcolepsy.
Sorry, narcolepsy, sorry.
Yeah, of
And
course.
other two are.
Other-
Okay, pitolisant, it's talking about pitolisant. Yes, it is FDA approved. Well, again, see, when we talk about the FDA approval, I think in India, we do not need to go for the FDA or whether it's approved by the FDA or not, because FDA approval is altogether a different kind of process. So there is a lot of medications which are actually approved by the FDA for a particular condition, but the guidelines, they go against the use of those medications or those kind of therapies. So please do not go with the FDA. Please look at the scientific evidence which is available for a particular condition for the treatment of and the use of particular medication for the treatment of that condition.
How to signpost clients for sleep studies when the amenities are limited in your locality?
Okay. Well, I think the same question was asked to me by a pediatric neurologist just yesterday. So Klein-Levin syndrome is basically a clinical diagnosis. You do not need any kind of sleep study to do for the Klein-Levin syndrome. But yes, if you are looking for some kind of other differential diagnosis, which can lead to the Klein-Levin syndrome, maybe the most common clinical mimics for the Klein-Levin syndrome are the shift worker disorder or insufficient sleep syndrome. So in those cases, actually, you can go for either the actigraphy or the just you can download a sleep diary, which is a paper and pencil kind of instrument, and you can give it to the patient. Most of the patient are able to fill it and give you the clear data. So that can help you to ascertain the diagnosis from the KLS mimics.
Yes.
Sir, is zopiclone included in NDPS? I think the question is.
Okay, NDPS, I'm not sure. I don't think so.
Even.
I don't think so. There was one question which was asked at the beginning. It was a like general question, sir. Like maybe if you want to take it up, you can just decide. So, can socio-political and socio-cultural factors have influence on the phenomenological presentation of a psychiatric illness? Can the way disease presents itself be modified by cultural perspectives and changing social values?
I think this is again a debatable question. Of course, because when we talk about the psychiatric, not only the psychiatric disorders, but also the other medical disorders, so different people, they have different explanations regarding their symptoms and their experiences. So definitely the way these symptoms are perceived and communicated, they can be influenced by the socio-cultural aspects and the even maybe the political aspects as well. But the core pathology regarding any of the medical disorder, and when I say medical disorder, I include psychiatric disorders as well and sleep disorders as well. So the core pathophysiological process will not alter. Just the explanation and the way it has been communicated to you can differ.
Sure. So I think those are all the questions. The one question which was related to what if there are limited facilities in your locality, and if you really want to, there's just a sleep study. Is there any alternative for it to just have a sleep study?
Well, I think it's a very difficult question to answer. If you are looking for the home sleep apnea testing, and if you are going by the guidelines, then there are a number of people, the distributors of the PEP, who are offering this almost for free, so you can use them. But the kind of patients, the sleep disorders that we usually get in the psychiatry practice, I don't think so they are fit candidate for the home sleep apnea testing, and they should be actually referred to for an in-lab attended polysomnography. So I think you need to network with the closest available sleep lab which is available, and say before you refer the patient to the sleep lab, please ascertain the qualifications of the people and the experience of the people who are actually say scoring the sleep studies. The reason is most of the softwares which are available for the sleep study, they give an auto scoring, which is often more than often actually is give a flawed report. So unless the person who is looking at the data, he is having a decent experience in the scoring of the different kinds of sleep data, please do not rely on that report. So I would rather say that you try to develop the expertise in yourself, and there are ample opportunities which are available. And you can look for those opportunities in various labs, in the various institutions which are working in India and abroad.
In short, there are no shortcuts.
Yes.
I happen to read upon on this availability of bed sensors which can actually monitor your sleep time, and also on this wireless EEG that they talk about, and there are some data available on this using artificial intelligence to correlate the sleep data and further developing a model of sleep-related disorder classification. So that was interesting to read upon. So maybe if you have some thoughts about it, you can just share.
Yes, I think, look, there are two different kinds of AI data that is available these days. One is based on the questionnaire, so that can give you a decent idea about what is the clinical condition the patient might be suffering from, because it comes through a specific questionnaire and then it follows a particular algorithm. But so it gives you a decent idea, but yes, in definite complicated patient, it may not work. Secondly, regarding the different kind of, we have different kind of devices. Some of the are the consumer grade products and some are the medical grade products which are available for the diagnosis, mainly for the sleep apnea, which are available. But if we look at the scientific literature, then none of the consumer grade products, for example, you talk about the different kind of smartwatches, you look at the different kind of apps which are available for the smartphones and which claim to record your sleep as well as the non-REM sleep. So, and then there are multiple other devices which are available. So we don't have any very good correlation of those devices with the in-lab polysomnography. Similarly, multiple medical grade devices are also available which record different parameters directly or indirectly. But again, their utility is limited so far, and the data is again limited regarding whether they can be used in place of in-lab polysomnography as of now. Maybe 5 years down the lane, 10 years down the lane, they might also improve their algorithms, their sensors, And maybe 10 years down the line, we would say that yes, you don't need to come to the sleep lab, and many of these sleep disorders can be ascertained by we will give you some kind of wearable device, and that you wear for the 2 days or 3 nights or 5 nights, and that will help us ascertain these issues. The only wearable device that we have available so far, and which is actually recommended, is the actigraphy. And I already talked about that actigraphy can be used for the diagnosis as well as the follow-up of insomnia, circadian rhythm sleep disorders, insufficient sleep syndrome, and certain hypersomnias before you are going for the MSLT.
Thank you so much for sharing that information. Yeah, I think there are no more questions there. So I just wanted to just say just a few things about it. So anyways, thank you so much for that wonderful, informative knowledge sharing session that we had today. And yeah, so we look forward to actually be in touch with you if at all we have some doubts about the sleep related disorders, because definitely we learn from each other. And for the postgraduate purpose, I thought since it's a topic on subspecialty, they can also read upon the lot of good articles in IJP itself. So one in the March 2022, it's on consultation license psychiatry. I happened to see upon that wonderful article. So they can just read upon this license psychiatry, consultation license psychiatry, past, present, and future. So, and the role of CL psychiatrist is very well described in that article. And they can also look upon some in IJP forensic psychiatry is also like a past present. That was very old article, but it's in 2016. So one interesting area that I came up on the subspecialty is also the psychotherapy. So which is a very interesting subspecialty, and the emergency psychiatry. So the emergency psychiatry is one area which the CBME curriculum also has included. It's to be mandatory in the first year of post-graduation. So I think most of us working in medical colleges will be implementing CBME curriculum for postgraduates. So the first year should have emergency psychiatry posting. So as mandatory. Right now we have, like, we send our PGs on call, but they say that they have to be posted there for a period of 1 month or so, which is mandatory for CBME curriculum. So I'm glad that the CBME curriculum has also expanded on the inclusion of subspecialties. So we have tried to incorporate transplant psychiatry as one of our elective posting. So this is also gaining much interest among the subspecialty. And of course, there are subspecialties involving specifically for transgender population. So because that's one more area that is actually growing up a lot. And we have to have certification process and surgery related concerns and other mental health issues of that subset population. So if you just look at then we will be like how we narrow down from child psychiatry to perinatal psychiatry, infant psychiatry. So like that, we may be narrowing down into subsect population as well. And we may have to in future gear up for actually therapies also like more narrowed down in terms of subspecialty. So thank you so much for that wonderful presentation. That's my final safe words.
Thank you.
Thank you. I think over to Dr. Kakunje, but before that, let me thank Dr. Kakunje and IPS for giving me the opportunity to chair this session, and a wonderful talk indeed, very thought-provoking and really good for postgraduates, especially who are struggling with recent advances. I think that was really wonderful. Over to you, Dr. Kakunje.
Yeah, thank you all. And for especially Dr. Ravi Gupta for accepting and speaking on a very tough topic. And I thank Dr. Ravi Gupta for his time, experience, and both the chairpersons, Dr. Janvi and Raman, to agree to chair the session and sharing your expertise. We actually had a diverse audience from all over India, right from north to south, east to west, more than 100 participants. Both we have postgraduates and consultants also joining. And we actually have had prizes for the best questions too. For the last webinar, there were 3 prizes given for the best audience. So I can just name them: Dr. Jagriti Yadav from Rohtak, Dr. Harshit Garg from Delhi, and Dr. Colin Braganza from Goa. So these are the 3 winners who will get Recent Advances in Psychiatry book to your postal address. We have all your details.
Congratulations
So
to the
that
winners.
so winners of this session will be announced in the next one, and they will also get recent advances book, so that will promote some interest in recent advances in psychiatry. And finally, thanks again for the audience, because without whom this program cannot be a success. I thank IPS, my publication committee co-members, the executive board, and our sponsors for making this program happen. Thank you one and all, and good night. We expect you to join our future sessions too.
Thank
Sure.
you.
Thank you.
Thank you.
Thank you, and have a great good night.
Good
Good
night.
night.